Now, the question that I put out earlier today, are you a supervised or medical directed CRNA? So what's the difference between supervised and medical directed? There is a difference, and a big one. Medical direction is the most restricted model that we have, in which the physician anesthesiologist needs to fulfill the seven steps of DEFRA regulation to be able to submit for a billing payments as a medical directed. And the biggest ones are obviously they need to be able to have assessed the patient in pre-op, regardless if you did. They need to be able to be in the induction, be at the extubation, be at some point in the middle of the case, and then a couple more. Pointing to this is it's the most restricted. So they need to be available at the beginning, at some point in the middle, some point at the end, in PACU. It's, and they need to do it. They need to be there. It's a presential situation. It's not like you have to be around in the hospital while you're doing all this. No, they need to be in the room. Is it better? Is it worse? It has no benefits in safety. It has been proven by evidence. It is more expensive in the sense of having two providers doing the same job. It is also, in a way, as far as like recruitment and retention goes, probably one of the area, the anesthesia models have the biggest problems keeping people, or at least the people in there are there not necessarily happy, don't enjoy work. And again, same thing is, if you're trained in that environment and you work in that environment, also you're used to that environment. So might also never be a problem. Are they bad? Are they worse? No. I mean, they're just, a type of model. And I think it's important for any CRNA resident or new grad or to know what they're getting into. And what is there around too? I mean, what are the practices you can practice in medical directed places when you can practice in a good place? Supervised is a different thing, right? Supervised, and it's not necessarily well used because it's, as far as the billing goes, it doesn't necessarily takes advantages all the possible revenue that anesthesia company can obtain. But it also, it's a supervised model in which physician anesthesiologists need to be available, but not necessarily in the room and in every part. And they don't have necessarily a limit on how many CRNAs they can supervise. And then a lot of these places you find in which, there's one physician that is the coordinator, and then they have 5 or 6 rooms, they're all CRNAs, so they have 4 CRNAs, 3 CRNAs, and 1 physician. And so those are a lot more flexible and usually are found in places in which the state's regulations are a little bit more limiting. So then you need to be able to use this in places that are the state's laws are necessarily not this limited. Then this supervision model doesn't really work because it actually decreases the amount of revenue that you can obtain. So are you ready for practice? And that, that's we go back to what the intention of this lecture is for. So as a CRNA, there is always the thought of like, I need to go and, work in an ACT practice in a big university setting for a couple of years to be able to be independent, or to be able to be protected, or to be able to get a lot more experience. So the question is, are you ready for practice? I mean, you go through school, lots of cases, a lot of experience. Yes, there's a variation on the spectrum on what type of experience you get in your programs. But the day comes and you need to be ready or not. So are you ready for practice? That's a question. Are you ready for independent practice, right? And then I can tell you for experience, I thought the same. I asked someone, they told me 5 years experience before you get into independent practice. And that's what I had in mind. So I was working on a, ACT practice for a couple of years. And then we'll talk a little bit about this in a second. Ask those questions to yourself, right? Are you ready for practice? Are you ready for independent practice? And on that note, so the independent practice states, you see this in this page. And this is important to kind of keep in mind as globally, what are our CRNAs residents being trained and what areas, and are you ready for practicing independently? You know, when you look into what our CRNA programs are, right? And the CRNA independent states, we have about 47 CRNA programs, and non-independent practice CRNA programs are in the 2-to-1 basically ratio from independent states. The majority of the graduates are being trained in states that have limiting laws for CRNAs. Does that make it more difficult for CRNAs to practice independently or jump into a in full independent practice from the get-go? You will think yes, right? Because if you practice in an environment that is really restricted, you train in an environment that's really restricted and really difficult to be exposed to, you know, independent CRNAs, then you will think that you are. For some people, it will be. Again, 80% of CRNAs residents train in ACT only sites. CRNA education had a recent updates to it, just increased the required cases from 600 to 650. Again, most of us do a lot more than that. Now we find that there's a requirement for specifically US guided regional cases and vascular access, central lines and things like that. It didn't used to be anything. POCUS training, there is not a requirement, but a requirement to track. So you have to track whatever you do with POCUS, and then this will become a requirement once they get some information about that. Radiology, it's also added to it. Did not have anything in radiology before as far as the CRNA residence requirements. Pre-anesthetic examination, so pre-ops, right? This was a shock for me, but it's really important to keep in mind we're not required to document any type of pre-op, which is, you know, in the autonomous practice world, that is probably the most important part of your anesthetic. What's your pre-op? Same thing goes for post-anesthetic examinations. Comprehensive history and physical, which is not necessarily the same as a pre-op examination, but it's basically in the same realm. 50 minimal or not assisted inductions, which is so interesting. And you know, depending on what you practice, you know, sometimes when you train, sometimes you have physicians and anesthesiologists coming in and pushing your medication. A lot of people say, well, I don't care, it's not important. As a resident, this is important for you. You must be able to do your own induction medications, and now they put them as a requirement. So why do I bring this up at this point? It's because as a CRNA resident, as a new grad, as a, you know, young CRNA, what you call it, you might have not been exposed or required to do any of these things. Now they're going to be. And then so if you're not, and you know, realize that this is something really important. Mind that this was based on the negotiation and studies for quite a while, and there is a spectrum of opinion-based experts, in which some of them said too much, most of them said that's just not enough. So this is where it comes from, brand new out of school, and these are the new requirements. You know, pathway to independent practice, you can also say pathway to practice, period. You know, what is it? You know, for independent practice, right out of school, is it 5 years of school, after school, or 10 years? You know, apart from whatever the right answer is, I went to independent practice 2 years after working in pretty restricted ACT models, and I trained in a state that I was, you know, it's pretty restrictive. So every model that I trained at, it was an ACT, a medical directed model. What is the right answer for this? You know, I can tell you in my own experience, which I'll talk a little bit about in a minute, it depends on the provider, you know, it depends on the resident. It depends on where they come from, right? For example, where we are right now and my practice, which I'll talk about it a little bit later, we, when I went to work for them, Providence Medical Center in North Seattle, Somnia company, Somnia practice, I actually did not have 5 years experience, did not have any experience in autonomous practices before. And the requirement that they had at that point was, you know, to be able to work in our practice, which is a collaboration practice, you know, physicians and CRNAs, you have to be at least 5 years of experience, which was not what I had. So I actually pushed a little, and based on my prior experience to this, which you'll see what it is, they gave me a chance, and you know, appreciate it, because at this point right now, 4 years later, we are able, and I'm very proud of hiring CRNA residents, new grads coming out of school for many different places and successfully doing so. So that's just a tidbit here. When are you ready? It's only a matter of when you want to say, I'm ready for this. You get prepared, you look at the areas in which you think you might need a little bit more reinforcement, and then just walk into that path to freedom in a way. So what does it look like when you start in CRNA school, CRNA anesthesia residency programs? You know, my experience was kind of like this, right? You know, you're in a sea of a lot of knowledge that you don't really understand yet. And then there's a lot of big sharks around. And I mean sharks, I'm talking about, you know, school, I'm talking about preceptors, CRNAs, physicians, politics around it. So I went to a large school, you know, a lot of students, so not a lot of one-to-one training or educational, remote learning, which was good and bad, I believe. Clinical sites were in the area, which was kind of nice. Restricted practices all over the place. A lot of restricted learning. I did not have any experience training with AAs. I did quite a bit of cardiac. Had no trauma experience before I finished school. Very minimal obstetric training. Very minimal regional training. Only thing that I can claim as a badge of honor sometimes for my experience as a CRNA resident was I actually did about 90 cardiac cases. I was in a cardiac center hospital, and then so it was really easy to do that. I started working there, so obviously I was very comfortable with cardiac anesthesia. As a new grad, you know, my first job, it was, again, exactly the same what I trained. They offered me a job. I took it because I really liked it. But, you know, like any of us that train in ACT states or ACT hospitals, you know, you find all boys club, not just for MDs, you know, but also for CRNAs. You know, they've been there for a long time, and then the people that you train with, you know, are going to be the people that are going to supervise you or medical direct you as a CRNA. The only thing that you kind of get out of it is that you're kind of getting a layer out of your current training, right? Difficult part of it is breaking through the student status, right? Remember, you're there. The mentality that you have as a CRNA student, CRNA residents, you don't want to you know, rock the boat. You don't want to be known for anything. You just want to make it through without any issues. And then now you work there as a CRNA. So when the transition to that is really important, because it will make your life easier or more difficult. Students, push your own meds as much as you can. Now it's a requirement. CRNAs, new CRNAs around, make sure you push your own meds. Creating a reputation, it's really important from day one. And I said day -1 is because, you create a reputation before you finish school. Yes, you have to walk a line and you have to, please everybody, but at the same time, take every opportunity you can to create a good reputation, someone who is A, willing to learn, B, not afraid of, being a decision maker, a soft, really good communicator and things like that. So, take every opportunity to do that. Have a learning junkie badge. And this is important, especially in very restricted places. When you work in a restricted area with, physicians that are not willing to let you see their CRNAs specifically do blocks or do, big cases or do central lines. As a student, as a resident, you might even be able to do more than the CRNA does in those environments. So, put your learning badge on. And, a lot of the physicians that work in there are going to let you do things, going to teach you to do things, because a lot of them don't mind it. Now, when you become a CRNA, it's a different thing, right? Because in a way, they look at you as a competition, and they want to. And that's just a different ball game. But as a resident, as a student, use that. I'm learning. I'm here just to learn. I don't care about anything else. Just put your head down. Anyone that is willing and letting you do X or B, do it. It doesn't matter if you like them or not. Doesn't matter if they're nice to you or they're not nice to you. If they're allowing you to do that central line, to do that block, to push your own meds, lean into them, right? And be the first one, right? Don't let that old saying of like, no one's done that before here. CRNAs don't do this. CRNA students don't do that. To stop you from seeking those opportunities. Personally, I'm telling you, especially as a new grad, you are going to be able to be comfortable with all these things before you even start. Providence Regional Medical Center is what I currently work at. This is a 15-year-old practice that was taking over MD only practice that have been there for about 30 years. Obviously, big step. Currently, right now, we have about 17 MDs, all working independently. Obstetric CRNA practice, we have a pretty big OB obstetric high risk hospital that is covered by 2 CRNAs 24/7. Level 2 trauma, we do some trauma, especially day after trauma. We don't do call in the main hospital, so the trauma usually is at nighttime. I have a cardiac program with fellow trained physicians and anesthesiologists that run that. We do not do trauma cardiac there. And again, like I said earlier, this was a 5-year minimum experience required to be able to apply to this job when I got in 4 years ago. Right now, we are not doing that. So we're hiring new grads, and we have just hired about 7 or 8 in the last 2 years with really, really good outcomes. Safety being kept. Our CRNA practice hasn't been damaged in any sense, and just enjoying to see the new grads and coming in and just shining in our practice. And obviously, this wasn't not without work. The leadership and Providence, and including myself, have worked really hard on creating an environment for CRNAs, new grads, specifically that is safe for them to start. We do OP sparing. I do. We're part of the medical staff, which is really important. LATO regional. Now we have nurse and sociology residents that come in more often from Gonzaga. So circling around, from my training to my first experiences as a CRNA, and then ending up in a practice like this at this point, it's a journey that I have gone through, right? As a CRNA resident in a restricted environment, and just kind of working my way through here is a big step, and I'm so thankful that the practice that I landed is what they are. I'm very proud of it.